but that's okay. So thanks for joining us. I want to start by saying that we have to reschedule our December 16th webinar because I have to make presentations at 2 meetings of the Speakers Task Force on Behavioral Health that day related to analysis I've been doing around the gap in mental health and substance use services in each RSA in the state, which will be information that I'll bringing back to you as soon as that's finished, which will have a lot of relevance for the work that we're doing together. And so I'm wondering, let's see, so I was hoping to reschedule to Wednesday, Thursday, or Friday of next week instead of Tuesday. And I'm just trying to think if you have a way of raising your hands on this. I don't think so. So let's see. I'm just going to ask.
We can type in.
Oh yeah. Okay. So let's see. What I'm going to start out. I'm going to ask people. I'm going to pick the day that I'd like to start with for scheduling. And for everyone who's sitting, with more than one person in a room, I'd like you to say, if I hear from, tell me what days works, type in which of those 3 days work for you, is what I'd like you to do.
It depends. Do you want to give us times, Dale? Because it'll depend on times.
Yes, on the screen I have Wednesday from 2:30 to 4, Thursday from 2:30 to 4, and Friday from 9 to 10:30. And so I'm just going to go into a cone of silence right now, and I'm going to be recording what people are saying.
May I ask a question of Don or Bunk? Do we have a Provider Alliance meeting on the 17th at 12:30?
We do not. There are sufficient meetings with Dale that we didn't think it would be necessary.
Okay.
Dale, this is Pat from Children's Center. I can do Thursday or Friday. Wednesday if it's an absolute must.
And this is Melanie. I can do Wednesday or Thursday.
I can't. This is Don. I can't do Thursday because I had to rearrange what I was supposed to do at Directors Conference today to that Thursday. So that's why I'm able to attend today. So I could do Wednesday or Friday.
This is Kirby. The only day I can't do is Friday.
Typical. That was Pat.
Actually, you guys, I'm going to the Nutcracker.
Oh.
Okay, so we have a really wonderful mix of days that people. So there are important people who can't do Wednesday, who can't do Thursday, and who can't do Friday. And it seems like it's equally that the days that don't work are relatively equally distributed.
So let me ask you about, can more people do Friday, Dale?
It looks like more people can do Friday.
So as long as the group remembers that I did this, I'll say yes to Friday.
Friday works for me too, Dale. This is Bunk. I just waited till Kirby yielded before I...
Bunk, I yield to you every time.
Okay, great. So Friday it is. I'll send out the email in the appointment, and actually I'll work really hard at getting the materials out to you more than 12 hours in advance. Thanks, everybody. I'm sorry about that kink. I know that we worked really hard for people to adjust their schedules to make this work. Okay, so that was, I don't know, like 5 minutes of recording that whoever's going to watch this is going to get to see, and I really apologize to all of you who have to go through that. So on to the show. For those of you that weren't on the first webinar or who are so busy that you can't even remember that far back, in that first webinar we talked about a few things that I think are really useful. A little bit about how the state is moving to integrated funding, which everybody knows, which was a way to start the conversation, and that we're really moving into an era where purchasers and payers are focusing on the triple aim with a special emphasis on bending the cost curve. And when I say purchasers, I mean the state is a purchaser, the health plans and BHOs are payers. So in terms of definitions, I wanted to just clarify that the purchaser is the state and the health plans and the BHOs are payers. And there really is a huge push for the purchaser to expect the payers to be focusing on the triple aim, and that's becoming an expectation for the providers. And some health plans are working with behavioral health providers to wrap care around the most expensive members and keep them out of the ER and hospital. And I'm thinking about the Inland Empire Health Plan example that we talked about. But we also talked about how many health plans don't know how to address the whole health needs of folks with behavioral health disorders. And we need to make sure that the early adopter contracts pay very close attention to the needs of persons with behavioral health disorders. So that's kind of where we left that. We have a work group. I haven't fired it up yet. It's going to get fired up at the beginning of next week. There's people that have volunteered to participate in that. And so be on the lookout if you volunteered for emails that are going to talk to you about this. Hold on just a second while I do one more piece of housekeeping. Okay, that's good enough for now. The second webinar, we had a little different conversation where we focused on, hold on just a sec, sorry. We focused on the fact that your clients are among the most expensive and complex folks in the system. And that you need to be seen as part of the whole health triple aim solution, or you won't be seen as a long-term value-added partner, and your organization may end up being toast. And so that's led us into this conversation about behavioral health centers of excellence as a useful compass for helping you know where to point your noses around getting ready for this new exciting environment. We covered some of the behavioral center of excellence components. We're going to finish them up today. And then we talked a little bit about certified community behavioral health clinics will be a major vehicle for helping you up your game, and how this is a whole new ball game in terms of the community behavioral health system, and how most people in the country don't realize what a game changer this is yet. But that's not, the CCBHCs aren't coming until 2016 or 2017, and so you need to focus now on how to be seen by your community as a Mayo Clinic of Behavioral Health. So that's part of the reason why we got this project rolling in 2014 rather than waiting until 2015, and so we're off and running. So what I want to do today is talk about what the health system of the new future looks like, including a 3-question test, sort of a fun test, and how do behavioral health providers become a valued part of this ecosystem, and how can you work together to get to the future faster and more effectively. And we're gonna start that conversation of how you work together, and then in our next webinar next week, we're going to dig much more deeply into that third question. So what does the health system of the future look like? Well, I'd like you to consider the following. Quotes, the past is a foreign country. They do things differently there. Prediction is very difficult, especially if it's about the future. My interest is in the future because I'm going to spend the rest of my life there. So I know that those are my little playful ways of saying that human beings are wired. So this is the closest thing to a scientific fact that I can sort of say, not being a scientist, but we're wired to just perceive the future as being like the present and the past. And so there's every day when I think about the future, it doesn't matter what the question is, I always think about it from the frame of reference of what the present and the past is. And what I'm trying to tease out with my little jokes here, or my quotes, is that we really have to try and break our natural instinct to think about the future looking like the present, because the past really is a foreign country. They do things differently there. And so this, I'm going to paint a few pictures about this. What does the health system look like in the future? Silos of excellence. So that's question number one. That's a yes or no question. And I hope everybody answers no. Question number two, what does the health system of the future need to look like? Different payers paying providers with different payment models that sometimes conflict with each other, to individual providers who all do different things to address different parts of the body, which is also known as achieving isolated impact. So I hope that you answer the second question, that no, the future does not look like this. Integrated funding supporting integrated delivery systems is my third question. Does the future look like this? And this is what I'm suggesting the future is going to look like, and this is what I want to talk about a little bit. That the Regional Health Alliance, or the accountable community of health working in tandem with health plans and local governments and other payers, the whole purpose of these ACHs is to get the payers working together to come up with a single set of performance measures and payment models and contract terms as much as possible, to give a single set of messages, not to individual providers who are working individually with no connection to each other, but to a system of care that really wraps care around individuals with mild, moderate, serious, and severe behavioral health disorders, people without behavioral health disorders, kids, adults, older adults, through new service delivery vehicles that are connected to each other inside some kind of accountable system of care where they all have interdependencies and are working together. And so there's a bunch of accountable care organizations that have grown up, that have sprouted up around the country, where they're at risk together, and where they're managing patients together, and where they've developed shared IT. And oh my gosh, it sounds like Kaiser. That's what Kaiser is. Kaiser is an accountable care organization. And what I'm suggesting is that the future is going to look sort of kind of like Kaiser, except it's going to be multiple organizations that are working together as a virtual accountable care organization, and that it's not just going to be medical care and behavioral health care, that inside that integrated system of care are going to be social service agencies, employment and education providers, public health, housing, oral health, long-term care, etc. And that another term for these accountable systems of care are health neighborhoods. So the accountable systems of care are going to support health neighborhoods where everybody is basically working together, all healthcare is local, to really create single care plans with single care teams working across multiple organizations. So in a nutshell, there are going to be places around the country that get here faster for the safety net population. There are going to be places in Washington State that get here faster. Those places are going to produce better outcomes and better cost and become really good friends with the people that have the money, because they're going to be achieving the triple aim a lot more efficiently and effectively than anybody else in the ecosystem. So if I just stopped right now and said, this is what the future looks like, I would feel like I sort of almost kind of accomplished the picture that I wanted to paint. I want to talk about five more slides, but before I do that, I want to stop and go into a little 15-second cone of silence and see if anyone has any questions or comments about this picture.
This is Don. I'll jump in with a quick question. So Dale, one way to look at this is that it's where you have a one-stop shopping, right? And yes, you can go into one location and a variety of services. How does some of the community-based ACT-PACT, children's intensive services with wraparound and everything, how do those mobile services fit into that model where they're already mobile and they're going to the families where they are?
Yeah, great question.
Include crisis in that answer, please.
So I'm going to show you a couple pictures and a couple of slides. I'm going to give you that go into a little bit more detail than that. But I'm going to give you sort of the sort of high-level answer that I think is the right thing to say now, which is bricks and mortar are way oversold, and the future is going to look a lot more virtual than the present, and people are going to be getting care closer to where they live, that there's going to be a lot more care provided out in the community than provided inside buildings, that there will be one-stops, they'll be the anchor tenant of the ecosystem of the health neighborhood, but there's going to be way, way more services provided outside the one-stop than there is now provided outside all these silos of excellence that are bricks and mortar facilities. And so the model that everybody has to come to someplace that may not be where they want to go as their only choice for getting care is going to be outdated really fast. And when I say virtual neighborhood, social media is going to play and telemedicine is going to play a really big role in the delivery of information and actual health care. And there's amazing things that are happening around. There's some health plans that are actually, and some companies, let's see, let me get a little more radical. Google is scanning people's searches around health questions, and in certain, they've developed this pilot project where they're saying there's a little screen that pops up and says, I haven't done this yet, I haven't had this happen to me yet, which says, would you like to talk to a doctor about this thing that you're researching? And they're actually providing telemedicine for free to people who are simply looking something up. And it's really kind of the future is not going to look like the present in a really big way when it comes to bricks and mortar. Kirby or Don, did you have any sort of follow-up questions or comments about that?
No, I appreciate that. I'd love to learn more.
Agreed. I just think I have to think about how crisis services fit into that.
Well, crisis service. So we're going to see in a few minutes that one of the required services to become a certified community behavioral health clinic is to have mobile crisis services. There's the cool work that's going on, starting to happen in your neighborhood, and really cool things are going on around the country are a whole re-envisioning of mobile delivery teams where social workers are part of police teams and EMT folks, firefighters who work in EMT, the EMT part of their system are becoming care managers, and they're instead of just their job being to take people to the hospital, that's it, end of story. Their job is to actually figure out if this is somebody that I know on a first name basis. I've been there 20 times in the last year, and I know that they actually don't need to go to the ER. What they need is to have their TV fixed or something like that. And it's we're going to have our whole heads flipped upside down about the role of people being out in the community providing supports to folks who are in crisis in having more than just a psychiatric crisis. But we haven't figured out exactly what that's all going to look like. So I'm expecting that you guys are going to be part of figuring that out. Some of you have seen the next few slides from some of the other presentations that I've done but I brought them back in case you all haven't seen it, or if you all haven't seen it 6 times, it might be worth seeing it again, because in many ways this is part of the future. Do you know about Atlanta? Do you know about Fulton County, Georgia, which is where Atlanta is, has an objective to create health neighborhoods and one-stops where people receive a holistic set of services under one roof that you can see are customized to the needs of the neighborhood. And so I did a site visit there. Neighborhood Union Primary Care Partnership was the first of 4 one-stops that they were developing. It's where the little A is, and this is in an old elementary school. And at the head of the system, spend an afternoon driving you around to the first 2 one-stops. And what we found, so here's a little drawing of the old elementary school. If you look straight at the building at the end of the parking lot, that's where the medical clinic is. And if you go around the L to the right, the dental operatories are there. And then the buildings closest to us, the part of the building closest to us has behavioral health and employment. Well, let's look at what's in this clinic. There's well patient care, sick patient care, OBGYN, travel, immunization, communicable disease, intervention, WIC, nutrition, education, oral health, behavioral health. So we've got a health department here. We've got a primary care clinic here. We've got a behavioral health clinic here. We've got a dental clinic here. And we've got employment assistance, discipline, voc rehab, foreclosure prevention, housing assistance. And basically what they've said is what do the folks in this neighborhood need? Let's try and get as much of this under one roof as possible, and have that be the model. The model is wherever we have services, we want to try and move away from having just one service, because most people who are being crushed by the social determinants of health because they're poor and finish that sentence with lots of other things, have more than one thing going on with them, and to have them go to multiple places really is not a good idea. And you know this from the folks that you work with. So then I went to the second one-stop, and you can see that there's a big green space around it. And it had everything that was in the previous one-stop, but then you can see it has a daycare center for kids and parents receiving services, a branch of the public library, a reading room, that also an information center that offers English as a second language classes. And as you can see, you can pay your parking tickets and taxes. And there's a farmer's market, a community garden, and a walking trail. So I was really kind of blown away big deal. And I know that that you've got this big building in Vancouver, just east of the freeway, that that was really designed as a one-stop. So I'm not assuming that all this stuff is new to you. I'm just trying to paint a picture of where things are headed, so that you can test out where do you provide services and how close do they, how much do they look like a one-stop, or how connected are they to a one-stop that's someplace else. And so what I'm predicting is that the new ecosystem is going to be made up of neighborhoods throughout the region, all healthcare is local, that will begin to organize, in some cases, Atlanta-type one-stops that aggregate and integrate services that help community members move towards health, supported by a large supporting cast. And so this gets to a little bit more detail about Don's question. So I have my Health Neighborhood One-Stop Shopping site, but there are people that are stationed or that go to do mobile work in apartment complexes, community centers, schools, assisted living facilities. There's mobile teams all throughout the community. And behavioral specialty clinics are part of that future ecosystem. But they're a much less prevalent part of the ecosystem than what exists now. So I don't know if you've heard me say this before, but about a year and a half ago, I came to the conclusion that if you work in behavioral health, about your clinic, and if you work in a building that has a bunch of other people that work in behavioral health, either as support staff or direct service providers or administrators, that building is not likely going to forever be a silo of excellence where there's just behavioral health people working in them. What I think is going to happen is that all of the buildings are going to be emptying out, and so that, like what they're doing in some of the projects that I'm working on, is they're saying we're going to send a third of you out into the community, we're going to embed a third of you in other one-stops, we're going to only keep a third of us in our clinic, and we're going to invite other services that our clients need to co-locate with us. So we're going to basically play musical chairs with our staff. And so I'm not talking about building new buildings that are triple the size. I'm talking about musical chairs. And it's more easily done with some types of services than others. But people are going to be stationed out. There's a lot of real estate out in these communities where people are that actually have the potential of lending themselves to the kind of services that you provide. I'm going to show one more picture, and then I want to stop and see if you have other questions, which is another version of this new ecosystem. So if we think about the One-Stop Health and Wellness Center being in the middle, and we think about the neighborhood also having community-based prevention activities going on, these are the kinds of services that I see being in the neighborhood. I'm not going to read them off, but this is just starting. There's a much longer list. These are the ones that sort of came on my first draft list. And you can see that community health teams are out in the community. Employment and education is really important. Human services is really important. Housing and homeless services are really important. That in this model, the One-Stop Health and Wellness Center / medical health home serves as the hub. So what people are starting to do is they're just starting to think about the hub, this idea of a one-stop being the hub as opposed to the only building. There's projects around the country that are being called accountable care communities, which is similar to what Washington is doing. And the hub is serving as the lead care coordination entity in some of these models, the one-stop. there are required anchored tenants in the Atlanta model, and I think we're probably going to find that primary care, mental health, chemical dependency, and oral health are the 4 anchor tenants. And what I mean by anchor tenant is in this model of a one-stop health and wellness center, if you think about what people need, what most people need, these are the 4 services that you're going to find in many of the one-stops of as anchor tenants. But it's important to note that care providers not located at the hub are the spokes, and they're supporting the integration of care so that there's a single care plan for each person and family that choose to use that particular health neighborhood / accountable care community and / accountable care organization / Kaiser with support services added, and that there's electronic connectivity so the care plan is available to all members of the care team. All members of the care team may not be working in the same place. Behavioral health people are going to be working alongside. Medical people are going to be working alongside. Dental folks. I'm talking about the future not looking like the present, and it's really curious to think about how quickly your neck of the woods is going to get here as opposed to whether you're ever going to get here. So again, I'm going to go into a cone of silence for a few seconds and see what kind of questions you have before we move on.
DL, do you want us to type our questions or say our questions? I typed one.
Great. Either way, thanks for reminding me. There's going to be let's see, I'm going to just do a little station. I'm going to come back to something in just a minute. Sorry. So the theory of one-stops is great. Reality is different due to the fact that our systems are generally built and built through appointments which manage access. Good and bad outcomes due to this model. What do we do in the future? What's your idea? So I cannot tell you how many behavioral health clinics people who are leaders in behavioral health clinics that I'm talking to that have gone to same-day, next-day access, open appointment scheduling, so that they've developed this whole model where you can come in, you can either schedule an appointment for same-day, next-day, you can come in without an appointment, and they've structured their care delivery so that people generally don't have to wait that long. And so I think that, but I think it's really complicated when you, like if you have 4 services, so what Kirby's basically saying is if I need 4 things today and I go into, how do I schedule like 4 appointments and have them all be for the same day? And if there is open access, how do I really be able to get what I need from 4 people how do I decide which office do I go in first? I mean, this is, you kind of like need to hire the Disney Corporation that's done amazing work around queuing theory, and they still have long lines to help figure this out. But this is going to be an evolving state of the art of how we're going to be figuring this stuff out. And again, a lot of people are going to get the support they need through a telemedicine / virtual internet-based model. But I think that the biggest piece about Kirby's question is open access, drop-in ability to get care rapidly with drop-in services or same-day, next-day appointments. But I don't know, Kirby, what thoughts do you have about that?
I think we all have, from talking to the people on those are providers on the phone in our RSN system, we all kind of morph a little bit of that, you know? We have same-day we call them crisis appointments. But I guess I struggle with, I think it's a fabulous theory. There's no way I can call the clinic across the street and get a next day or same day appointment at primary care for a person that's sitting in my office. I can't, I mean, and I know that you can't in Clark County, which is worse access than here. I just struggle with, and because of hopefully the laborious paperwork of mental health and chemical dependency will go by the wayside. But when you have to do an hour assessment, and you have to do all these, you have to go through all these hoops. You have to close charts, which is ridiculous. Primary care doesn't do that. So I think that there's a whole lot of streamlining that's legislatively driven that needs to happen, and it seems like a great big huge lift, and I kind of get caught up in those details when I'm thinking about it.
So it's really important to do two things. Three things maybe. One is to keep your eye on the prize, which is how do we create a system that works for clients, patients, consumers, so that they're not re-traumatized. What kind of care would I like my care to be? Secondly, the serenity prayer, and we got to work on things. We have to focus on what we have control over, and then hope that there's smart enough people who are committed to patient-centered care to help work on the rest of the stuff. Oregon has been working on a project to create the same rules for mental health and chemical dependence, paperwork requirements for mental health and chemical dependency that they do for primary care. And it's really pretty darned exciting that they've committed to moving in that direction. I think that's going to happen elsewhere. Primary care access is a really big problem in Southwest Washington, and it's probably the elephant in the living room. And if we don't figure out a much more robust way to solve that problem, it's going to take a lot longer to meet the needs of the population than otherwise will be the case. And we just have to face that square on that it's really a huge problem. There are a lot of primary care clinics that are moving to open access, but it's still, I mean, if you don't have enough capacity, you don't have enough capacity. Let's see what else is in my slide deck. How do behavioral health providers become a valued part of the ecosystem? So I want to shift gears for a couple minutes, and I want to talk about my favorite topic in life, which is flowcharts, because I know everybody else loves flowcharts. So I'm thinking about the first part of the flowchart, which is the boxes around the perimeter called Plan, Do, Study, and Act, which is the quality improvement cycle. And the first thing that behavioral health providers can do to become a valued part of an ecosystem is to really immerse yourself in the quality improvement cycle, or make sure that your staff, that this becomes part of the DNA of your staff, is continuous quality improvement, which it is for some and it isn't for others. And in this version of the quality improvement cycle, we start out with education. How will healthcare reform change what we do and how we do it, which this webinar is part of that. Readiness assessment, what gaps exist between what is and where we need to be. We're going to be doing a readiness assessment with you. Planning and design, what are our redesign priorities and strategic initiatives? And those redesign priorities and strategic initiatives fall into two categories. They fall into external work. What do I need to do out in the community with other organizations, with policymakers, with funders? What do I need to be doing internally to make improvements in my organization? And so we're going to pick up we started talking about internal work around behavioral centers of excellence. We're going to pick up on that in just a minute, and then we're going to shift gears and talk about external work. And then evaluate whether the changes that we made are working. And if not, then we need to go back and do some rework or do some other additional improvement cycles. And if they are working, then we need to ask ourselves, what's the next phase of redesign so that we don't bite off more than we can chew. So I was joking when I said I know that everybody loves flowcharts. Flowcharts are like equally hated by, I think, everybody in the whole population. But this little picture of the steps involved in getting ready for the ecosystem, I want to underscore that you all need to be doing external work improvement projects and internal work improvement projects. So let's get back to the components of behavioral centers of excellence and see what kind of comments you have. And what I have, so we discussed easy access and customer service last webinar. We just touched on comprehensive services. I'm going to pick up where we left off. So these, you may remember, are the 5 components, the 5 of what we've been focusing on our Behavioral Center of Excellence project. So let's talk about excellent outcomes. Bucket 1, the work we do makes a measurable difference in people's lives, and we can demonstrate our excellent outcomes and high success rates with data using validated clinical instruments. I would suggest that everybody who works in health, anywhere in the health neighborhood, whether it's health, behavioral health, housing, human services, etc., are going to be put into one of 2 buckets. And the bucket that we want to be in is that we actually can demonstrate that we're making a measurable difference in people's lives. And the second bucket has really 2 parts to it. We can't make the above statement either because we aren't measuring well, but we believe we provide great care, or we actually have started tracking outcomes and we're not as great as we thought. So like it or not, the near future for everybody on this call is that your payers and your patients and family members are basically going to be creating some version of these 2 sentences and putting you in one of these 2 buckets. And even if you do great work, but you're not measuring so that you can't prove it, that's going to land you in bucket 2. And I would suggest this is a massive change in how things have worked for the last 50 years. And so what does that look like trying to get into bucket 2? Well, you know, Behavioral Center of Excellence is known for achieving results for clients, and the organization can measure what is important to clients and achieve excellent outcomes on those measures. So that's like a real quick blurb. Let me just make this a little bit easier to read. Hold on just a sec. Okay. So I want to talk about outcomes. So the definition that I'm going to show you comes out of the University of Washington from the work that they've been doing around integrated care. And the component, their definition of outcomes-based care has these parts, and I'm going to read through them because it's really important and add a few editorial comments. A multidisciplinary care team works with an individual with behavioral health disorders to complete a multidimensional assessment. And so at University of Washington, and their model is medical and behavioral health providers are part of that multidisciplinary care team, the multidimensional assessment is looking at people's health conditions as well as their behavioral health conditions, and hopefully other psychosocial conditions that are relevant to their health and wellness. The assessment is used to identify specific and measurable goals for individuals, including at least one clinical goal and one personal goal. I was just talking to a researcher from Southern California who works in a very large children's organization, who is doing, which is a really great organization, and she said, you know, when I read people's treatment, the treatment plans of my coworkers, and I look for specific and measurable goals, I can't find them most of the time. That what the clinicians write down as goals are just, well, as a researcher, they don't cut it. And what she's saying is that that organization right now is in bucket 2, not bucket 1, because we got stuck at step number 2. The client and their team develop a professional care plan and a self-care plan that includes setting targets related to the goals, utilizing validated tools to measure improvement. So we've been having this conversation about what are the tools that community behavioral health centers ought to be using. Across the river in Health Share in the Portland metro area, they're developing a menu or an inventory of clinical tools that are already being used, that they're vetting for whether they would allow you to do this kind of measurement, be able to set targets and measure on a regular basis whether people are getting there. And they've got like 20 tools that they're going to be testing out. And what they're going to be testing them out is basically using this outcome-based care approach, focusing on specific and measurable goals, measuring on a regular basis. They're using things like the PHQ-9, the ACORN, the Scott Miller tools. There's a whole bunch of stuff that's on the list. The team supports client engagement. Throughout the process, engaging the client in all aspects of care planning and treatment, understanding how the client is progressing through the stages of change, and providing high-touch care management. And the client and team monitor progress in a persistent and individualized way to determine whether the care is working, using the clinical measurement tools to determine whether the targets are being reached. There are regular case reviews with the team and with the client to determine whether the care plan is working or needs adjusting. If targets are not being met, care plans are changed. Electronically shared information is available to all members of the care team, ideally through the use of a patient registry that includes the care plans, medication list, and results of the outcome tracking tools. So what HealthShare, the mental health component of HealthShare across the river, Clackamas, Washington, and Multnomah counties, what they've decided is that moving to outcomes-based care is the single most important innovation that they need to be doing in the mental health system in the Portland area, period, end of story. Because they know that if they don't get from where they are now, which is bucket 2, into bucket 1, well, they're just not going to be able to get the kind of continued funding because they have integrated care now. There's the respect, the connectivity with the rest of the ecosystem if they don't focus on this first. So let's see. I just said like a huge number of words to you about a rather complicated concept. Questions or comments? Okay. A couple more things, and then we're going to shift gears. There's a new definition of value in healthcare. I'm working on a project in Arizona where the state has already told the Medicaid health plans that they have to start doing what's called value-based purchasing on the healthcare side. They're actually moving into their third year of value-based purchasing. On the mental health side, they're starting this in 2015. And so we're working on a project to figure out how to develop a toolkit for folks in the state, the health plans, to implement value-based purchasing in a way that the providers can actually succeed at it. And I want to talk about the new definition of value in healthcare very briefly. My services are effective in achieving individual outcomes and system-wide outcomes. So if we can't tackle the outcome-based care piece that we just talked about, we're stuck at the starting line around value-based purchasing because we can't measure whether people are getting better. My services are more cost-effective than alternatives that may have been selected is something that many people in health and behavioral health care have not thought about. So here's what I hear all the time. You know, I'm doing this really great evidence-based program, and it's costing $1 gazillion, but it's getting really good outcomes, so we should still be funded. And what I say is maybe you're right and maybe you're wrong. Because if there are other treatment protocols that can get the same outcomes, as good or better outcomes for less money, then you're wrong. It's not good value for me to pay you $1 gazillion when there's an alternative that has been demonstrated to work just as well for less money. Now, that's a really subjective conversation that we've just started that may never get resolved. So it's not black and white, but that's the kind of, when you have a very expensive program, you're going to have to demonstrate that that what you're doing for the population you're serving is more cost-effective than alternatives that may have been selected. This is a new sort of expectation that's coming your way. And my services are lean, meaning that waste, excess costs have been removed through process improvement activities. So if somebody else can provide the same package of services for 10% less because they are more efficient than you, then you don't have as good a value as them. And that's the new, these three components all fit together as the definition of value, and it's really different than what the bar that's been put up for you in the past and present. And one more thing about excellent value, don't forget we can't measure value if we haven't developed internal cost allocation systems to allocate costs down to the service code level so that we can roll them up by client, team, or any of a number of other groupings. So this is just a little schematic of some model building that we've done in the past where you take expense data from the financial accounting system and you take visit data from your billing system or your patient accounting system and you combine the two into a cost allocation system where you're able to identify what the cost is for each service that you provide, and then and this isn't the charge, this is the cost for every service you provide, and then you can roll them up into reports that say, here's how much everybody with depression cost, here's how much every young woman between the ages of 12 and 17 who had depression cost last month or last quarter, last year, etc. And you can't do that until you systems that allow you to crunch numbers in this way. One last thing is comprehensive care, and then we'll shift gears. So I did a blog post earlier this year, My Killing My Patients, and it had the quote that you all know about people dying 25 years early. And the reason why that's connected with comprehensive care is it's really important for you to think about the full continuum of care for what folks need who come into your clinic. A Center of Excellence is known for offering a broad scope of mental health, substance use, and co-occurring disorder services that are integrated with medical care and other services and supports. There are very few organizations that can do it all, but that doesn't get you off the hook. And I want to talk about that a little bit. So SAMHSA came out with a list of 9 services that they describe as a modern mental health, what needs to be in a modern mental health care system, with care management as the connective tissue. So these are the sort of SAMHSA 9 that when we say, do you provide comprehensive care, this is kind of what the list is. This has been superseded by the work that's come out around behavioral health, community behavioral health clinics that I talked about 2 weeks ago. And I want to dig into, I didn't talk about this 2 weeks ago, but there are 9 required services for you to become a community, a certified community behavioral health clinic. And for those of you that weren't on the call a couple weeks ago, let me just add one sentence. The near future, you're either going to become certified as a community behavioral health, certified community behavioral health clinic, which is a federal designation. It's never existed before. It's brand new. The regs haven't even been written yet. Or you're going to be TOAST. Now let's see, there's one more option. You're going to be certified as a CCBHC, which is the behavioral health equivalent of an FQHC. Or you're going to be partnered with a CCBHC contractually, or you're going to be TOAST.
So what's the timing on this, Dale?
Let me show the 9 services, and then I'll grab, I'm going to go get another slide from another presentation and drop it in and answer that question for you. So you have to do crisis mental health services. This is what I'm showing you now is straight out of the law passed by Congress. So this is like cast in stone, including 24-hour mobile crisis teams, emergency crisis intervention, crisis stabilization, screening assessment, diagnosis including risk assessment, patient and or treatment planning or similar processes, outpatient mental health and substance use services, outpatient clinic primary care screening and monitoring of key health indicators and health risks. You don't have to be a primary care clinic. You have to have the ability to screen for asthma, diabetes, hypertension, etc., monitor those conditions on an ongoing basis, and make sure that those conditions are managed. Big, important piece of the puzzle. You have to be able to provide targeted case management, psychiatric rehab services, peer supports, and peer counselor services and family supports, and intensive community-based mental health care for members of the armed forces and veterans. So those are the 9 required services for getting the Good Housekeeping Seal approval that's going to have money that comes with it that I'll tell you about the timeline in just a second, but I want to go to the next slide first before I go grab the timeline. We're not going to see the regs till next spring, but provider organizations are going to likely be able to partner with each other to achieve the full array of services for all age groups. And so how this is probably going to play out is there will be a lead organization. Like if you're a small provider that doesn't have that full array of services, so CCBHCs are going to get extra funding. They're going to have extra benefits. There's a whole list of things that we will talk about at another time about the benefits of a CCBHC. If you're too small to become one, you probably are going to be able to ride on the coattails by having very close contractual relationships with a CCBHC. And in the contract, there are going to have to be assurances that what you do fits the definition of excellence and fits the requirements of the CCBHC that they have to meet with the feds before they make you their best friend and contractual partner. So when people say, does everybody have to merge, are we just going to go away if we're a small provider? My answer to that is no. That what we're really looking at is either becoming a CCBHC or becoming a partner with a CCBHC. Let me grab that one slide. Hold on a sec. And while I'm doing that, please feel free to think up what other questions that you want to ask.
So Dale, have they gotten as far as to lay out a process for this, or have you? Okay.
Yeah. So I'll explain when I go through the dates. So between now and March, the feds are developing the criteria for what a CCBHC is. They're developing the PPS requirements, which PPS is the prospective payment system, which is how CCBHCs are going to be paid. They're developing a planning grant application form that I'll talk about in just a minute, and they're planning ways that states can certify CCBHCs. What are the options for certification? And so that's up till next spring. Late spring, the feds are going to release all this stuff, including the planning grant application. And here's the deal. What they're going to do, what they're doing is they have $25 million. They're telling all the states, we want to give you money to do planning for this CCBHC thing, which is coming. And here's what you need to do to apply to get the money, and it's not very hard. And so they're pushing money out to support the states in getting ready for this. Those applications will probably be due in the summer, next summer. And then what the feds are going to do is they're going to award the planning grants to pretty much anyone and everyone who applies, as long as it's even slightly legible. And then the states will have a year after they've gotten the planning grant, which is actually a design period, to create the infrastructure to support CCBHCs, to actually certify CCBHCs in the state, and then to prepare for the payment model change, and then prepare an application to become one of 8 pilot CCBHC pilot states. So, which I'll say more about in just a second. And what's going to happen is that, let's just say that 25 states get planning grants. And let's say that they're $1 million apiece. And let's say that 20 states actually get through the year to the point where they actually fill out an application. What they're asking for is to become one of 8 pilot states that will get $1 billion. Yes, that's right, $1 billion over 2 years, spread out among those 8 states, to support the demonstration of whether CCBHCs can actually work. And I'm predicting that before President Obama leaves office, they will select the 8 states. They'll probably identify all 8 at the same time. The law is written that they could stagger the selection process, but I think President Obama is going to want to pick all 8 before he leaves. And then in calendar year 2017 and 18 will be the 2-year pilot where centers will, that are certified, that are going to be doing a proof of concept around these 9, providing these 9 core services and improving quality and doing outcomes-based care and all the stuff that I'm talking to you about. You're going to, if Washington gets one of the grants and your center is certified as a CCBHC, you'll be basically doing this work, proof of concept for whether you can bend the cost curve, whether you can achieve better outcomes for your patients that are dying 25 years early than what was going on before CCBHC. So the whole idea here is there's a lot of people that complain about the behavioral health system. Well, if it's underfunded and there's no accountability, there's no national accountability structure, we don't know whether the complaints are real or not. But we do know that if you don't have enough money, it's really hard to get great outcomes. So we're going to test this out to see if you guys can step up. If the feds give you $1 billion to test out this project in 8 states, and then we're going to decide to spread it to the whole country like FQHCs or not. So I predict that that this is going to be a really big deal, and I don't know whether Washington State is going to get its act together to go after this. But even if it doesn't mean that you should just pretend like it's not going to come your way sooner or later, because a lot of things that are in here are really relevant to your adding value into the ecosystem.
So would this go through the healthcare authority, Dale?
What happens is the money will come from the feds to the, so what's going to happen, let's just say that that Washington became one of the states, and there was $100 million that came over 2 years. So that's $50 million a year. That money would be used to, the plan that the states puts together is going to say, here's how the money will flow, and here's how it will be used to meet the requirements of the grant. And the requirements of the grant are basically going to say, you got to make sure that those 9 services are available and funded in all the CCBHCs. You need to make sure that they're doing care coordination and care management in the ways that the contract requires. There needs to be an evaluation process that you need to put in place. So you're going to need to spend money on that. And we don't know whether, so that money will come to the state. And by 2017 or 18, we don't know whether it will go to DSHS or the Healthcare Authority. And that's something that will have to get argued about between now and then, before the application gets turned in the late summer of 2016. So I actually don't know the answer to your question.
I'm kind of hogging questions, but I'm just going to ask one more, then I'll not do that. So Does early adopter or BHO status play any kind of a role or overlap in this?
So if you're an early adopter region and there's no BHO, there's just a health plan, then the question about whether it goes to Healthcare Authority or DSHS becomes a moot point, because it will most likely come to the health plans who will have requirements on how they need to spend that. That's how it works. That's kind of sort of how it works. The FQHC system sort of kind of works in the state. It'd probably be not dissimilar to how the FQHC system works, which is the health plans pay the FQHCs their prospective payment and counter rate, and then the state makes a wrap payment. And there's money for some of these additional services that needed to be provided. If you're in an early adopter region that's aggressively working on integration, you're going to be much better prepared to meet the requirements of being a CCBHC than if you're in a non-early adopter / BHO region that isn't aggressively working on integrated care. So that's the other piece of the puzzle that's, I think, relevant to this.
Thank you.
Other questions or comments from the gang? So I just have 2 more slides. A sec. So if you think about everything that I've just said, well, it's a little bit daunting, because I'm saying that you have to become best friends with health plans, pitching that you can help them bend the cost curve for their most complex enrollees. I'm saying that you have to become best friends with the primary care system, helping them deal with their most complex patients. That you have to become best friends with all the providers in the health neighborhood, because you have to work together to wrap care around folks with a single care plan. And now with this CCBHC thing, I'm saying that you have to become best friends forever with other behavioral health providers as you're working together to ensure that you have all 9 services under your roof. I forgot to say something. I bet you $1. Everything I say is speculative because the regs are not, but I bet you $1 when the regs come out, they're going to say that you can't be a CCBHC if you just serve kids but don't serve adults and older adults. Or you can't be you can't get certified if you don't serve young people. That they're going to probably be looking for you to serve all age groups, but I may be wrong. But the point is that I think that the system is basically expecting comprehensive care from these CCBHCs as a minimum entrance requirement. And so, yeah, go ahead.
This is Brad. Just so I understand, when you can be an alliance or in this partnership, but there will have to be a single backbone organization within the alliance. Is that, am I correct in understanding you that way?
Yeah, so what I'm saying is around the CCBHC thing is that there's going to be there's a legal entity that will apply to the state to be certified as a certified community behavioral health clinic. And when that application goes in, the organization will say, it will say, here's who I'm including in my application. See, I have a bunch of employees, and then who have all these disciplines, and then I have some contract employees, like half my psychiatrists are all contract employees. They're part of my CCBHC, and then I have some contract other organizations. That are part of my application as well, in the same way that my contract psychiatrist is part of my application. And so like CVAB probably can't be, isn't going to do enough to be able to meet the criteria, but CVAB could come in under the wings of another organization and take advantage of the benefits of CCBHC-ness.
Or a children's organization could come in under an adult serving co-occurring kind of organization, or so it could be a lot of different partnerships that provide that specialty care where no one organization may do that.
That's right. Or if an organization only saw adults, then the children's organization may be the CCBHC with the contractual relationship with the adult provider. So it could be vice versa. Yeah.
Right. All
That's
right. Thank you.
So again, like I was involved in helping do some of the analysis for SAMHSA this summer on what CCBH, the requirements ought to look like, but they've gone into their own cone of silence, and we won't know what the regs are until the regs come out in draft form for comment, and then that probably won't be till next spring before we hear from them. So let's see, the last thing I want to say is, let's see, I sound like a broken record. The near future does not look like the present. So you know, as we soak on all this stuff, I really want to shift gears now and talk about next time about what are the options for becoming best friends with the new ecosystem. And so, you know, one option is you can become part of, remember that first picture I had in my 3-question test, part of a local accountable care organization that includes behavioral health providers, healthcare providers, and other services and supports. So what I'm saying is I have colleagues around the country that are going to the hospital CEOs in their community, and they're saying, we want to be part of the accountable care organization that you're starting, and here's the business case why it would be stupid for you to do anything other than make us a charter member of the ACO because of what we bring to the table. They wouldn't quite use that language, but that's the message that they're giving. So that's one scenario. Another scenario is becoming part of a behavioral health accountable care organization that takes shared risk responsibility for the cost and quality of the persons that enroll with you. So this doesn't exist right now in your neck of the woods, but you would basically create not a whole health ACO, but a behavioral health ACO. And there are folks around the country that are working on this. And you would be responsible for doing CCBHC stuff to help keep people out of the hospital and out of the emergency room in partnership with the primary care system. A third option is becoming part of a behavioral health network that supports contract negotiation and provider collaboration, and also does training and technical assistance so that you're working together to get ready, but you're not you're not part of any risk-bearing arrangement that's in option 1 or option 2. Or you could become part of a behavioral health association that's a less formal version of a behavioral health network, which is kind of what you are now. You call yourself the Alliance. I call you a behavioral health association. And at the same time, you would create closer contractual arrangements with one or more providers in order to achieve the competency, the capability, of doing all 9 services that are on the CCBHC list. Or you could become an acquisition target for a larger health system. I cannot tell you how many folks I've talked to that are doing this. And of course, not of course because you may not know this, but in Washington State, what's now Good Samaritan Behavioral Health did this like 15 years ago. They became part of the Good Sam health system, and they were a community mental health center for many years. There was no connection between the healthcare system and the behavioral health system. And then as they started working on integration, they pitched becoming much more closely integrated, and they've become like the go-to integration team for all the medical clinics in the Good Sam system up in South King County, Pierce County area. And merging with one or more behavioral health providers and also doing one of the above or not, depending on what you look like when you come out the other side. And what you'll see about all 6 of these things is I don't have a 7th one which says stay the same. Because I don't think that any of you will succeed if you pick option number 7 as all these wheels start changing. So we're going to talk about this in a lot more detail. I suspect that when we start doing some face-to-face work and some individual work, we're going to be going into a lot more detail about centers of excellence and the internal piece and this external piece. But I think I've covered everything I wanted to cover today and provide some food for thought as we get ready to explore these options and what they mean in more detail next time. So I've babbled at you for almost an hour and a half. Questions?
One more question. So can you kind of tell us what how much time do we have to make this decision, and then after that decision's made, how much time is there to implement the decision?
So let's see. What's really great about your question is I'm going to tell you a story that I think will make you feel a lot better. Even though I don't know the answer to your question, the story that I'm going to tell you is going to give you a very concrete answer. So I do a lot of work in Oregon. It was like the beginning of March a few years ago, the state put out a request for application for communities to self-organize into becoming coordinated care organizations as opposed to accountable care organizations. So if you know anything about the Oregon system, a coordinated care organization is kind of like a hybrid of a health plan and an ACO. So it's the closest thing to the list here is number 1. And they said you have 45 days to fill out this application. I can't remember whether it was 45 or 75 days. I'll look it up so that I get my numbers right, but it doesn't matter. Let's just say it was 75 days. And it's like anybody in their right mind would fall over and faint and say, this is impossible. How can we go from what we are now to being to filling out an application demonstrating that we're ready to be a coordinated care organization, because it's way more heavy lift than anything on this list. And the whole state self-organized, and they completed the application, and what they basically did was they described how they were going to come together over the next 3-year period, very carefully staged phase 1, phase 2, phase 3, and the state said, fine, and they gave them all contracts. And with the point being that the state knew that these local communities couldn't get 100% of the way there in 75 days. What they were trying to do was to get them on the journey to getting there. So as you become clearer about how you all want to organize externally to come together, you need to figure it out. I would suggest in the next 7 months, by the end of the first half of calendar year 2015, so that as health plans get notified who's going to be the health plan for the early adopter regions, you can start pitching to them whatever your pitch is around contracting. But you don't have to have created the new entity by next June, or even have fully created it by January or April of 2016 when these contracts go into effect. But you got to get on the journey by next July, I would say is an absolute essential piece. And so what I'm saying is that between now and next July, if I believe, and I'm right, if I'm right that there isn't an option 7 for you to look exactly the way that you look now, I would suggest it's really important for you to get on that journey by then. Start that journey. So on that note, we're going to call it a day. It's 4 o'clock. Thank you so much for putting up with me. And there's a Southwest Behavioral Health training on MDD, I'm assuming that's Major Depression Disorder Friday, that's going to preclude at least one person's involvement. But I think we'll just go ahead and I'll send the material out and the invitation out for next Friday. Thanks, everybody. I appreciate all your time today.